Beautiful words. Really, I admire that. Thank you very much. I will not be generous as Professor Bashar and Professor Riyaz Malik. I will save you 2 or 3 minutes. Bismillah ar-Rahman ar-Rahim. My talk about impact of Ramadan fasting in people with type 1 diabetes and diabetic kidney disease, insights from the DaR Global Survey. Despite the scarcity of data, we can conclude that the individuals with type 1 diabetes and diabetic kidney disease considered a very high risk, moderate to high risk, according to the DaR risk calculator, and individually advised against fasting in many instances. But according to the global data, DaR global data in 2020 and 2022, this subgroup analysis of Diabetes and Ramadan Global Survey was conducted to evaluate the outcome and characteristics of patients with type 1 diabetes complicated by DKD who observed fasting, and to compare their outcome to those fasting individuals without uncomplicated by DKD. Keep in mind, we are here talking in the DaR Global Survey about 13,000 patients with diabetes, and talking about 2,000 about the type 1 diabetes. The methodology is was difficult, specifically designed survey non-key questionnaire. Muslim individuals with type 1 diabetes and diabetic kidney disease were surveyed in about 23 countries and 5 continents from different geographical regions, compared statistically to people with type 1 diabetes without DKD with associated comorbidities. Here, all the data was published with my great friends here in this article. We are talking about 200 individuals with type 1 diabetes. From them, DKD constitute 160 patients versus 200 patients with no DKD. So those with non-DKD is about 13 times more. Regarding the results is somewhat gloomy. Here we see that the age of the patients is somewhat similar between the patients with DKD and those without DKD, but the duration of diabetes, supposedly, it's about somewhat similar in a way that duration of diabetes and DKD somewhat 2 years more than those with control. Regarding the A1C, regarding the presence of comorbidities, it's more. The duration of, the hemoglobin A1C is somewhat poorer to be controlled. Insulin pump users in the DKD group was in 24 patients, constituting 15% of the patients, compared to 22.6. And the use of pump and those who fasted or not fasted will be delayed for their explanation to the next session, where Nancy Berberi and Professor Asfiani will talk about thoroughly regarding the pumps. So, concluding that older age, longer duration of diabetes, and poor glycemic control affect the DKD in general. These are in general. Now let's take the subgroup, the DKD, and those fast and those who didn't fast. As you can see, the age group is somewhat similar, but the BMI regarding those who fasted is in the overweight, but better. Hemoglobin A1C, it is suboptimally controlled, but 8.5 plus minus 1, and it is somewhat similar to that of non-fasting. LDL less than 100 is somewhat, really, it's better for those fasting. And the insulin pump user, you can deduce from here that the insulin pump users are better protected even with their DKD. The characteristic of fasting for those in general, we will take now in this slide, we will take those who fasted in the DKD and compared to those who fasted from the non-DKD. There was 54% of type 1 diabetes with DKD cohort intended to fast, compared with 74% with type 1 who without DKD, with a significant association. Conversely, about 46% of the type 1 diabetes DKD patients group, number is 74, choose not to fast, highlighting the fact that DKD can affect the fasting decision. The average number of fasting days were nearly similar in both groups and even in control. And this affects also the post-Ramadan fasting rates, which were marginally higher in the controls, though the difference is not significant. Why did the DKD affect everything on the lifestyle of these patients? You can deduce from this slide that hypertension, hyperlipidemia, retinopathy, microvascular in general, and macrovascular complications were more in those who didn't fast. While for this slide in particular, the patients who were CKD group had more complication regarding hypoglycemia. Imagine or notice that 65% of patients with CKD had experienced any hypoglycemia, frequent hypoglycemia, and about 13% hospitalized for hypoglycemia, and about 5% shift to the hypers. There are 70% of the patients had hyperglycemia, but those who required hospitalization in a similar rate regarding hypos. So even with their fasting, they didn't complete the exact days. You can imagine here that only the duration of fasting regarding days were about 24 plus minus 9 versus 24 plus minus 7. SMBG and Ramadan-specific patients' education, which were thoroughly discussed during these sessions, were performed at more or less in similar or equal measures. However, education sessions run significantly longer for type 1 with DKD, well, and this is supposedly explainable, with 62% of the session running more than 15 minutes versus about 40%. The strength of the study, although we are talking now about 160 versus 200, this is largest real-world multi-country data sets on Ramadan fasting in type 1 diabetes with DKD, large sample size with wide geographical coverage, rich granular data on fasting behavior, complication, insulin use, and self-care. And you can imagine the limitation. We don't have the exact GFR because this is self-reported data by the physician themselves. No DKD staging, limiting analysis by severity, and I promise that the next generation of the studies will include that. Self-reported event of hypos and hypers, and risk of recall and reporting bias, cross-country variability, which may affect the outcome, a small DKD group per country, limiting geographical comparison. In conclusion, individuals with DKD and type 1 diabetes and generally older have more diabetes-related complications and comorbidities. This group is less likely to fast during Ramadan compared to those without DKD. Fasting carries a higher risk of hypos and hyper, particularly increased hypos and hospital admission. Safe fasting requires interdisciplinary care, strong patient education, and expert medical guidance. And in view of the new diabetes risk calculator, this will be more possible to guide our patients regarding their fasting decisions. So the strategic recommendation include comprehensive pre-Ramadan assessment, which are done very thoroughly. Individual risks classification using the DaR risk calculator, especially the next generation. Structured Ramadan focused education, encourage frequent glucose monitoring, improving access to diabetes technology, and integrating interdisciplinary team care models, prioritizing future research using CGM and DKD stage specific data. Really, I was generous. Thank you.